Right. Okay, I think there's one more question you can take later. So very warm good afternoon to all of you. Myself Prabhat. As I told, this session was supposed to take a bit of Atul, but he will be joining us with next Tuesday because he has official commitment. So what I will do in this session is that I will introduce to you the principles of management in opioid use disorders, and the next session Atul will speak specifically on buprenorphine maintenance treatment. Let me start. Yeah. Now, the disclaimer: you can use the slides definitely as a whole, but you can please acknowledge author or printer and demands for a whole thing. Yeah, I don't have nothing to disclose. The objective of this today's presentation is just to get a brief overview about the opioids and the addiction, review the currently available treatment strategy for the opioid dependence, understand the factors associated with the initiation and changes and challenges for this drug. I'll start with 3 case vignettes. These are the cases which you have seen across the last couple of years. This is a Mr. A, 30-year-old gentleman. He's actually a pharmacist. He used to inject pentazocine for last 10 years. He injects 10 to 8 ampoules per day. Although he does not share the needle, but he reuses the same needle in the in the areas. He initially started using heroin, that is brown sugar, and also benzodiazepine. But later, because of the financial issues, he shifted using injection pentazocine, that's 14. And the right side, you can see the multiple ulcers in the both the right and left arm, and you can see the left arm ulcer is more than right arm because he's a right-handed person. And this is how he came to us. He's married, not able to stick to his job with multiple stressor. Obviously, motivation is not very good. It's pretty poor motivation. A second case, this is a 45-year-old gentleman who used to drink, dried poppy powder, which in most of North India is known as bhukki or doda. This is basically a dried poppy seed which has been powdered. He started at the age of 37, following a peer influence. He used to take 100 to 150 grams of poppy per day. Basically, make a powder and mix in water and will drink it. And although at this point of time he does not get any pleasure out of that, but unfortunately because of withdrawal and craving, he continued to do it. Now, why he came to treatment? Now, one of the most important reason is increasing cost of the poppy powder at this point of time, and withdrawal symptoms, craving, and become expensive, and had sexual difficulty. This why it didn't have another problem. Third case is a lady who is a 36-year-old, started using tramadol, being prescribed by a general practitioner for the pain in the shoulder. He continued to take off and on for last 6 months. There were some interpersonal problem at home, and and followed by a demise of her mother. She started increasing the tablet using the tramadol to 6 to 8 capsules per day, and she used to feel a lot of energetic, more relaxed. And at the time of presentation, for last 3-4 months, he is taking 10 to 12 capsules per day. One day, when she was visiting her in-laws' house, he had a GTCS, had a seizure, and actually she fell down. That is the reason actually family came to know that she was using some medication, and they actually came to our treatment. Before I go to details about these drugs, just to have some brief, what is the meaning of opioids and opioids? Opioids is a generic term applied to alkaloids from opium poppy. There is synthetic analog and synthetic. So basically, it's a generic term for all the group of drugs. Because opiates is a plant derivative natural opium. So somebody talks about heroin or opium or opium, we think of opiates. Where opioids includes photoin, tramadol, codeine, everything. So this is a standard definition. This beautiful flower of opium plant, it's pretty beautiful. If you go to Afghanistan, probably you can see. I have not gone by the way.
Rajasthan, UP, you will see.
And this is the harvesting method. And basically, you need to see this is a pod. You have to give a cut mark in the pod, then the latex of the pod will come out, and you will harvest it. Then obviously it processed and sold to market. Coming to the brief about pharmacology, as all of us know, it works in 3 receptors: mu, kappa, and delta. Probably significant important one is a mu receptor for both analgesia as a euphoric effect. I have underlined that one. Other thing like mu, C, sedation, constipation, depression, respiratory depressions, it can happen with kappa also. Delta is for analgesic and conversion effect. So these are 3 effects, and higher the mu agonist, more likely to be addiction potential is the. This is how it works. If you look at the derivatives, the natural derivatives are opium, morphine, and codeine. For a semi-synthetic, which are actually from the chemicals of the opium, are heroin, oxycodone, and buprenorphine. For synthetics, are the plenty are available in the market. Propoxyphene, that is your spazoproxyphene, methadone, lam, tramadol, pentazocine, fentanyl. So this is broadly a classification of opioid drugs. And commonly abused in India, as you can see, the right side looks brown, which is actually heroin adulterated and mixed up with so many things, including Bonvita, whereas left side is pure heroin, which is white sugar. So basically, pure heroin is whitish in color, but unfortunately, because of the black market and other things, it gets adulterated, and you can see the brown sugar, which being very commonly used either chasing or intravenous by the people. Now, these commonly used synthetic opioids which we come across, the TDGesic, Bupigesic, Lupigesic, these are the buprenorphine analogs. I mean, used parenterally. Tramjac, Ultraset, I think you must be familiar with Ultraset, which has a combination of paracetamol and tramadol. Lomotil in North India, Dapanox is a diphenoxylate, which actually is a anti-diarrheal agent. Fortuin, or this is pentazocine, as you know, is a potent painkiller. Dextropropoxyphene, which is spazoproxyphene, SP, as famously known, contains dextropropoxyphene plus paracetamol and dicyclomine. As you all know that last year the dextropropoxyphene has been banned in India, so you have something known as spazoproxyphene plus. So now you get a lot of patients using spazoproxyphene plus, where the tramadol is replaced by the dextropropoxyphene. And local formulation, I think most of you must be seeing a lot of cases at this point of time, because probably last 6 to 8 months the price of opium has increased substantially. So people are using bhukki, doda, or poppy tea. There are 3 forms of dried opioids, dried poppy plant. Okay, now before I go further, I just want to introduce 3 terms in the opioid management. One is agonist, as a self-explanatory. Agonist is a drug which work like opium, like heroin, pentazocine. So partial agonist is a partial agonist and antagonist. It's a maximum effect but less than full effect. Antagonist, it doesn't have any effect on. So this, if you look at the thing, the orange color is the partial agonist, blue is the full agonist, and the green is antagonist. So the 3 groups of drug in the opioid used for the opioid treatment. Okay. Now, those who are new to this area and in opioid addiction, so these are the standard criteria for addiction for any substances. First is tolerance, where person needs more substance to get the same effect. Withdrawal, when the gentleman have reactions or adverse reactions if it does not use the substance. Using larger than intended. Persistent desire to cut down. Use despite knowledge of harm or having harm, like the first case or second case, he had injected so many, but in spite of he could not control and go using further and further. Spending a lot of time obtaining, using, recovering. If you remember the second patient, he used to tell me that yes, he is supposed to go to England to see his grandson, but he could not go to England because in flight he is not able to get the bhukki, doda. So he could go to Delhi, but what he does, he will call somebody in Delhi, and the Delhi guy will get the bhukki to the airport. As soon as he gets down, he has to take some bhukki. So life is crippled. Your life is crippled with accessing, obtaining, using, recovering, social obligation dysfunctions. Coming to goals of treatment in opioid use, which is slightly different from the other substances. Here the first goal is retaining the person in treatment. Invariably, most of the opioid users are motivation level is not very high. They're mostly young people, has multiple drug use. So first and important goal is to, can you keep them on the treatment network? Whether he stops or doesn't stop is second issue. So first, this is the first foremost important. Second point is obviously, can you help him to reduce the opioid, if not abstinence? If you can stop, well and fine. But if you are able to reduce the opioid, that itself is a bigger achievement. And decrease the frequency and severity. Most important thing is that, can you decrease the harm? As all of us know, that to get the opioid being illegal drug, you have to spend huge amount of money. To sustain the habit of using opioid, you need to have a lot of money. And here you'll get money. So you'll have to either steal, criminal activity, smuggle, peddle, going to prison. So if your treatment can decrease the harm which is following, itself is a pretty good achievement. And improvement of the functioning. So as you say, the first case we presented by Devanjan, in spite of so many difficulty, at least he could stop opioid. I think he's lucky, one of the lucky guys to stop. Probably is more intelligent and could think and stick to BM. Some sort of treatment is given, but it's not so easy. Now coming to the other principle of treatment, you have broadly two types of treatment. You detoxify, that is basically handling the withdrawal symptom, and maintenance, where you go for long-term treatment. For detoxification, we have two agents. We can use with opioids, with non-opioids. As I told, detoxification is a treatment of opioid withdrawal symptom. Withdrawal symptoms last for 1 to 2 weeks. Now you remember, the opioid withdrawal symptom is not a lethal withdrawal symptom. It cannot be fatal, but the morbidity is very high. So ask any patient, do you want to stop opioid? The moment he will tell that I don't want, because I cannot tolerate the withdrawal symptom. So although it is not lethal, but people relapse very quickly because they cannot tolerate the severity of withdrawal symptoms. Opioid like Buprenorphine and Methadone both can be used for withdrawal symptom, but in India, including our center, we have more experience with Buprenorphine than using Methadone. I will just briefly touch about how we detoxify with Buprenorphine. It's a sublingual preparation. We initiate at 0.4 to 0.8 milligram per day as per the withdrawal symptom and can be titrated up. The dose is actually guided by withdrawal symptom. There is no such called fixed dose regime. 6 to 8 milligram per day is enough to handle the withdrawal symptoms. So basically, you start 0.4 to 0.8, hike up next day 2 milligram. Next day you can go to 4 milligram. 6 to 8 milligram, you'll see dramatic improvement with the patients. Then you taper gradually over the period of 10 to 14 days. In our experience, the good part of buprenorphine thing is that you can return the patient in the treatment. Those of us who tried clonidine in our before days, we realized that we will not. One dose you start, they will ask for discharge, they will go away, they never come back to you. Here, the person you give a medicine, at least comes back to you and sits with you, and okay, I can continue treatment. So that is the advantage of using this medicine, at least. Methadone, you should always treat in inpatient setting because it's pure agonist. Start with 10 milligram per day and go up to 20 to 40 milligram per day. You can slowly taper down 5 milligram per day for a few weeks. And outpatient is not advisable for methadone, but maintenance is fine, but not for the treatment here. If you have some comparison about buprenorphine and methadone, severity of withdrawals is similar, but withdrawal symptoms may resolve more quickly with buprenorphine. Completion of withdrawal treatment may be more likely buprenorphine related to methadone. Again, in our experience, buprenorphine has been a very useful drug handling the withdrawal part, not only maintenance but definitely withdrawal part. And because it's easily available, I mean, it's widely, not widely also, it's available in India, so we should use it. And we have more or less shifted to buprenorphine based treatment for last almost 4, 5, 6 years. Now, but still, the places where buprenorphine is not available, or you have, you don't want to give, you can definitely try for non-opioids. Clonidine is the cornerstone therapy. It is centrally acting alpha-2 adrenergic agonist. Now, the advantage of clonidine is that it stops nausea, vomiting, diarrhea, cramps, and sweating. But the most important, not helpful, which I think the most important is craving. For me, the first 2-3 days of admission, all the withdrawal symptoms are there, but the craving with opioid is intense. Sleep problem is very difficult to manage, and with body pain. So those type of emotional or psychological symptoms are very difficult to manage with the clonidine alone itself. So you need to add on some sort of supplement with a painkiller sedative like non-benzodiazepine. So this is some sort of protocol. You can start day 1, point 1 to point 2 is all right, but point 1 milligram 8 hourly is safer bet. Day 2 to 4 slightly increase, and probably 7th day onwards start titrating. Only concern is that you need to check the blood pressure. It is notoriously famous to cut down the BP, and BP can fall below 90-60 with single or two dose. So any percent you are starting clonidine, do monitor the blood pressure and tachycardia, and skip the dose of clonidine if you BP falls significantly. Now let's come to evidence. Now at this point of time, the evidence is for agonist treatment, either buprenorphine or methadone. For buprenorphine is a choice for detoxification. As I told, it helps to return the patient in the treatment network. Buprenorphine is more effective than clonidine in reducing opioid withdrawal, retaining patients in treatment and supporting the completion of treatment. With methadone, buprenorphine likely to resolve the withdrawal symptom faster. So we have strong recommendation that you go for buprenorphine sublingual. Now 0.4 preparation is available plain. Average, so you can start with 0.4 to 0.8 and go up to 2 milligram. 2 milligram we have a combination naloxone. Dose being guided by the severity of withdrawal, tolerability, and clinical condition. Initiate the dose slow, and you should start the first dose when he is in withdrawal phase. The reason being, if he is not actively withdrawal, then he will have a precipitated withdrawal. So some pupillary dilatation, some physical discomfort, little lacrimation, he himself will tell that I am going to withdrawal. The best time to start, and increase by 2 to 4 milligram per severity. Most patients are 6 to 8 milligram, and slowly taper down 7 to 14 days, and both plain and naloxone effective. Now although some centers in India do use dextropropoxifen, as the first case been pointed out, where he went and told the doctor that you want to use dextropropoxifen for the maintenance, but later part he got hooked to it. So we don't use dextropropoxifen or tramadol for detoxification or maintenance treatment. But in case of non-availability, buprenorphine, clonidine can be considered, and I can try it. Just a small summary of the whole thing. If you look at the right side threshold of tolerability, if you use a buprenorphine methadone or buprenorphine assisted detoxification, you can see the graph there. Is much tolerable. He doesn't have to go through a very bad phase. Compared to untreated, you don't give any medicine and look at the severity of the symptom. Now he's beyond his threshold, and that is the whole reason people relapse to the started using heroin again when they go to withdrawal phase. Okay, this is a very controversial topic. I mean, all of us know that there is something rapid detoxification. In rapid, you start clonidine from the beginning, then you give either naltrexone, loaded naltrexone while the patient is on opioid. He would have severe withdrawal, basically precipitated withdrawal. Then you use clonidine. But in my experience, people have very bad effect. They will never tell. I mean, some people whom we tried with 12.5 milligram of naltrexone over clonidine when they're actively using opioid, just as they 1 day of stopping opioid, they do come back and tell that it's very severe and difficult to tolerate. Ultra rapid happens under general anesthesia. We don't have much experience, but it's not worth trying. IPS guideline writes that it's not worth trying. Deaths has been reported in this and which is I will not strongly advise not to use this method. Now, what happens after that? Whether you go for maintenance treatment or no. Now, let's see the data. Data tells if you detox somebody with methadone, 82% relapse within 1 year and 45% first 3 months. Somebody who is buprenorphine for let's 2 weeks and taper down, 82% lapse in 1 month, 88% 3 months, and even you give for 28 days means 4 weeks. There is no advantage also. So it means and clonidine high dropout. So overall, if you use only detoxification without anything, the relapse rate is very, very high. So you need to go for maintenance treatment. So detoxification leads to high relapse only. So you shift them to maintenance treatment. Now, in the maintenance group, we have two things: buprenorphine maintenance treatment, which most of the centers in India are using now, and methadone, which few centers are ending. Unfortunately, in India, it's a reverse case. Throughout the world, methadone came much faster because it's cheaper, and whereas buprenorphine came later. But India, it's like reverse. Buprenorphine came now, I mean, 5 6 years back, and methadone is coming now. So that's how it is. Why you need to give maintenance? I've already spoken briefly. Opioid dependence is a chronic disorder. Single episode of treatment seldom leads to long-term abstinence. And so the objective of a maintenance treatment is first is to reduce illegal and other harmful drug use, improve the patient's health and well-being, reduce death and other medical conditions associated with drug use, reduce crime committed by the patient, facilitate an improvement in the patient occupancy functioning. So basically, if you can return the person, then you can think of intervention. So this is a mode to return the person engaging in intervention, which is likely to help in the change in behavior. Unfortunately, again it's unfortunately, detoxification from opioid without pharmacological support afterwards remain the dominant mode of treatment. Still now in our country also, people just detoxify and don't give any agonist or antagonist treatment and leave it. And despite decades of experience and evidence to contrary, medication to prevent relapse are not routinely offered after detoxification. People are very ambivalent about agonist maintenance treatment. We don't know why, in spite of repeated research evidence, clinical evidence coming to this fold. I'll briefly speak about the ideal pharmacology agent. It should, for the opioid, should be blockade all illicit opioids, suppress withdrawal symptom, reduce craving, and reduce drug-related harm. Should be safe, non-toxic, free of side effect, not liable to abuse. Is very important. I mean, you should not give a drug which person again start abusing it. Good acceptability among patients. Duration of action should be longer. So, a few agonist therapy which have been tried, but the time-tested one are two: methadone and buprenorphine. Other drugs are used occasionally or refractory cases, and some are out. Some have used for some time in other part of the world, but not used now. As I told, harm minimization, and this is the aim here. Now, aim in agonist therapy is you substitute an illicit, medically unsafe, short-acting opioid, let's say heroin, with a medically safe, long-acting agonist of known potency, purity, and dosage. So, something you are shifting a person from, you don't know what is the potency, you don't know how it works, you don't know how long it works, to a drug which you know the drug, and you know the potency, you know the purity, you know the dose. So, I just shifting it from impure to pure. It prevents withdrawal, it reduces craving, a reduction of illegal other drug use, reduce drug-related criminality, and cessation of treatment. Different names are given: OST, oral opioid substitute treatment, oral substitute treatment, MMT, BMT, medication-assisted treatment. There is a lot of debate going on, in this field, because recent literature is suggesting if you are using buprenorphine or buprenorphine particularly, and you have an arm where you use buprenorphine, other research arm you have buprenorphine plus psychosocial intervention. So what research is telling that only using buprenorphine is good enough. You don't have to have a psychosocial. I mean, if you want to give, it's all right, but you may or may not have a psychosocial intervention. Now the people are asking that then why you want to tell assisted treatment? Do you take insulin-assisted diabetes treatment or oral hypoglycemic-assisted diabetes treatment? So there is debate going on. So and again, it shows the path of the clinicians or physicians or the patients on this medication, and which is controversy now.
Lack of faith.
Yeah, lack of faith. Obviously, people are ambivalent. Is always ambivalent. As I told, buprenorphine maintenance treatment will be taken by next session by Dr. Atul. So I'm not going to talk detail. I will give a glimpse on methadone treatment. The reason being, very likely you are going to use methadone treatment in most part of the country slowly. So you should know a little bit about this treatment. Now this is introduced long time back by Dole and Nice Wonder, husband wife, and it's a synthetic mu opioid receptor. Slow onset, reliable absorption and bioavailability, daily peak plasma level up to 2 to 6 hours after ingestion. It's a highly protein bound medicine, and as you see, it's a red color. Although it's available in tablets, but I have seen it as liquid. I've never seen a tablet till now. So this is a typical methadone clinic where you walk in the early morning, take your coffee plastic cup. They'll give one cup from one machine. Will come and pour 60 milligram methadone and drink. Go to work. So this is a supervised treatment, unlike buprenorphine, who is office-based treatment. It's a large erosion, it binds to tissue, and the best part is because of it is bind to tissue and slow release, it prevents the sharp peak of euphoria and withdrawal, which is very important for an opioid treatment. All the short-acting heroin opioids, they have a sharp peak. They get a sharp peak, then they fall, which leads to euphoria and withdrawal. Euphoria, withdrawal. Here is a drug which maintains some sort of stability. Now the general principle is it's a once-a-day dosing. Start low and go slow. General principle, because as I told, it accumulates in the body. It takes some time to reach a therapeutic level, and as it's a pure agonist, if you get intoxicated, you might have a respiratory depression. So you have to be careful. Look for withdrawal symptom at the beginning. Initiate 20 to 30 milligram. You can be low, but in Indian population, whatever the 5 centers they are giving, they give pretty low dose because they found that our patients are not able to tolerate 20 to 30 milligram at the beginning. Okay. Dose escalation slowly under supervision. As I written, you should always, the next day, see, often what happens, patient, you start the first dose of methadone, second day they will come and tell, no sir, it's not enough, can you increase my dosage? This is very, very common in methadone clinic, but you should not do it because it remains in the body and it accumulates. So you have to give 4 to 5 days because of the accumulation and slow dissociation before you hike up next dose. So you have to explain outright to the patient that this is how it is. Now, target dose 40 to 60 milligram is enough to block withdrawal symptom. 60 to 100 will be for the craving and illicit opioid use. Now, we have seen patients who are taking 120, 160 also, but 60 to 100 is enough. As I written, the tablet form I've never actually used, but the liquid is 5 milligram per ml. It comes and it's very cheap. So there's a reason of methadone being popular. If you look at the cost of the buprenorphine, is very high, and in a public health problem like opioid use, you cannot sustain asking patients to pay money and to give the medicine. Then you let me take money and get opioid, whereas methadone is much cheaper. So there is a hope that methadone comes to India soon, and we should use it. Now it's used in 5 centers as a pilot. Okay, dosage outcome is better with increased dosage. In general, it's a general rule for all buprenorphine and methadone. Always remember when using this maintenance treatment, look for high dose. Never be miser or stingy about giving doses. Beginning people will give 2 milligram. See, Panadol is very good, sir. I'm feeling very good. But 2 milligram is good for withdrawal. It's like if you're hungry, you want 4 chapati. 1 chapati is enough. 1 chapati can also decrease hunger, but you want 4 chapati. So the brain receptor has to be occupied fully to prevent illicit opioid use. If you see the last slide, otherwise what will happen? Like this patient who is taking buprenorphine, also taking spasoproxyphene, both together is going on because some receptors are still empty and you need to fill them up. So the doses for anti-craving is always higher than the doses for withdrawal treatment. So high dose of methadone is better. See, methadone is used for last almost 30 to 40 years, and I mean one of the best part of methadone is that it is safe in pregnancy also. Generally very safe. Others, see, all the side effects are opioid side effects. Constipation, increased appetite, lower libido, because as you know, all opioids suppresses the gonadal hormones, and generally it is a good drug. And exhaustive study has happened, long-term studies has happened. Nothing wrong in this drug. So outcome: retention to treatment, reduction of illicit opioid use, improvement in psychosocial function, help keep people who are dependent on heroin in treatment programs, and obviously few people continue to use opioid also. As I told, this will be next week. I'll keep the, I think spelling of Ambekar is wrong, but sorry, not Ambekar. Okay, sorry. Antagonist treatment. So now this is another mode of treatment in interaction. See, which is opioid antagonist. Semi-synthetic antagonist block the effect of opiate. Oral administration, rapidly absorbed, and it is significant fast metabolism. Basically how it works, it blocks the pleasurable effect of opioid because it blocks the receptor. So if a person takes another extra opioid, illicit opioid, he's not likely to get the effect. So they extinct the rewarding property of the illicit opioids. This is how it works. Now, as it reduces the craving related to reduced immediate effects of opioid, decondition or extinct curated craving. So if I am an opioid user, I have taken naltrexone. Hypothesis is that my receptors are blocked by naltrexone. So if I take opioid over that, I will not get the pleasurable because already my receptors are occupied by the antagonist. This is a hypothesis. But these are other facts about pharmacokinetic. Okay, advantage, no tolerance. It's not a scheduled drug. It's not opioid per se. But the biggest problem in this drug, I mean, I assume most of you must have used naltrexone in your practice. The difficult part is patient doesn't want to take it. So if patient doesn't want to take it, then I mean, how is it going to be useful? So the compliance and retention is abysmally poor. So poor so that I think this is the available evidence showed that no benefit of naltrexone in terms of retention up to treatment, side effect of relapse result compared to placebo. So which is I thought really harsh, but studies shows that is equal to placebo, which is probably true in the setting when you have used naltrexone, you're using other drugs now. So patients definitely prefer buprenorphine or methadone naltrexone. Frequent dropout, non-compliance is a big problem with naltrexone drug, and so something I just briefly touched. This is a new. It's not new. It's been used for a couple of years in other countries. Had shown a very promising result, which is once a month depot naltrexone injection. It comes in withdrawal in other countries, and good retention rate. But we don't have much experience in this molecule. There is something available known as an implant also, and again similar to depot, but there's some controversy of the implant. This is something I thought might help you. The recent one, which is basically you want to induce somebody, you think that person needs naltrexone and you want to start early. So you can start buprenorphine in day 1, day 2 increase the buprenorphine. Day 3, don't give anything. Day 4, start very low dose of naltrexone. See, naltrexone 3 mg is not available in India. So you have to crush the tablet and make some parts and give. Okay, which we have done in the past. But you have to cover under the clonidine, clonazepam, and other drugs. So this is a rapid method. So because why this regime has come, people realized during detoxification only people relapses. When they started the detoxification phase, first let's say 7 days, how people relapse. So if you can handle detoxification with buprenorphine, which is, as you know, smoother detoxification, then add naltrexone faster, which is like a rapid method, it will work. We are just started using few percent to see how it works. So we'll come back and let you know. I'll finish up in a couple of slides. The summary of intervention, I've given a comparison here. Now, methadone, buprenorphine are controlled substance. Control means you need certain degree of standard guideline or standard practice. In most countries, to prescribe methadone and buprenorphine, you need certain hours of training, like they call 8 hours of training at US and other countries, and obviously not for psychiatrists, for other professions. Availability restricted for methadone. Buprenorphine is office-based treatment. You can obviously write and prescribe. Retention rate is very high. You can see you can compare here naltrexone 20% versus 60% here. Expenses. I strongly feel that these drugs, like other addiction drugs, should be subsidized for the patients because these are public health problem. They're society problem, community problem. Unless you provide the treatment proactively, it's not going to work. And as you know, things are increasing day by day. Dosing frequency daily. Overdose potential. Yeah, that's why methadone is to be taken every day. Very important. Methadone cannot be given take home because overdose is very high. It's pure agonist, like morphine, so person can consume and have a respiratory depression. So withdrawal symptoms are severe when they stop it. Again, physiologically mu full agonist, mu partial agonist, higher bioavailability, half-life. Fortunately, both the drug has a better half-life. So that means even they skip one dose, they'll not jump to a very severe withdrawal, which is the basic principle of using long-acting opioids. Certain drugs have interactions. Coming back to the final part, selection of treatment, the case begins. Let's see the first case. As I told, first case was the pharmacist who has multiple ulcers in the arm. And what we did in that case was we admitted him. We have motivated him for agonist maintenance treatment. Although there is a financial difficulty, we provided to him free of cost. He is on buprenorphine 16 mg per day for last almost 2 years and is doing absolutely fine. Ulcer is healed completely. I could not take a photograph of the arm now. You cannot see any ulcer, although that scars marks are there, and no ulcer at all. He works a teacher, and obviously, how long will give? I think lifetime. There's no scope at all for this gentleman to decrease. Or we can review later, but I personally feel it's lifetime. Second case, who is to read Roda or Bukki. This case, obviously you can treat outpatient, and with agonist you can manage withdrawal symptom, but just withdrawal might not be sufficient in this case. He might need a short maintenance treatment, let's say 3 to 6 months, because there are neurological changes using for 20 years. So sudden, our clinical knowledge is that if you just do withdrawal and drop it, then they're likely to relapse higher. So you have to give for 3 to 6 months of buprenorphine, then slowly shift to naltrexone. Last case, this is a lady where we thought we'll use the withdrawal treatment, use his comorbid depression, and go for probably naltrexone based treatment. So take home message, buprenorphine maintenance or methadone maintenance is treatment of choice for opioid addiction. Antagonist treatment may be suitable for highly motivated, antagonist means naltrexone, who are highly motivated, short duration opioid use, less potent opioid use. I don't think, at least we don't get this type of patient in our setting. The patient we get our settings are highly long-standing use of opioids, multiple issues. So buprenorphine assisted withdrawal will be best for if you want to manage only withdrawal. Definitely psychosocial intervention is a must, because all have a comorbidity, have issues about temperament, issues regarding their psychiatric diagnosis. I land with a nice letter I got from a patient just 3 days back, and this letter was written by a patient. I don't know how much you can read. I'll just read. He is a mechanical engineer, and he used to take you can read codeine in form of cough syrups in 20 years, following certain family issues and difficulties in life. Gradually it increased, and it started affecting his life very significantly. And he's written, it's so powerful that I was nothing without it. No meeting, no training, nothing. He got slowly, he had to take this one to get a confidence to anything. I remember he used to tell me, he does architect, so he used to do some planning and in the computer, and unless there is a correct bottle, he'll never used to start his work. This is I'm doing 3 years back. After I realized that this devil was making me poor in everything, financially, professionally, dysfunction part came here. He tried to change to alcohol, smoking, didn't work out anything. He also writes that he's very, look at his family. He's from a stable family, children, daughter, son. Then he somehow get internet. So how internet is helpful, you can realize now. So he got a Niman's names, and he didn't believe that we can help him in treatment, and who will addicted for 20 years. Still, he thought, let me try, and he came to Bangalore. Probably he made our team. Discussion, explanation. I remember I had to literally coax him that I can treat you. You just get admitted for a few days. I need to stabilize you in the doses. Because it's a very far place in Karnataka, it's difficult to up and down. And normally in our center, we prefer to people to few days of at least initiation part to admit and to basically make some repo and all. Now, so yeah, he has improved. Now he's almost 1.5 years over, and you can see he started with 8 milligram of buprenorphine naloxone, 2 milligram 4 tablet. Now he is in tapering dose and takes only 0.4 milligram per day. So again, this reflects. You might have enormous amount of research, whatever research you do, but at the end of the day, you are a clinician. You are sitting in the table. You are trying to help the people, and this reflects, and probably, in spite of own limitation of this medicine, it believes that this can work. I think I'll stop with this letter. I'll leave it to you to read. Thank you very much. Questions?
We have a few minutes for questions. Can take questions now.
Yeah, I think.
So just a couple of questions. One is, in case this buprenorphine or methadone, both, is there any dose response relationship, or is there a ceiling effect beyond a certain dose, or is it that we can go up to a certain dose if the withdrawal symptoms doesn't come down? And the second is, when exactly do we take a decision, suppose a person is on BMT for some time, that we can now decrease it on maintenance, or we can now go for a transition to antagonist treatment?
I think the very relevant question. First is that what is the selling dose or threshold dose? Now, fortunately, with buprenorphine, it's much safer bet because buprenorphine is selling for respiratory depression, or there's no selling for other things. So, even if you person is on treatment phase has a withdrawal symptom, you get the buprenorphine, not responding, you can go up further and further and further up. No issue at all. Till 32, nothing will happen. Further, because there is a plateau on the depression. So increase in dose not going to increase in respiratory depression. So you are safe. So that's why you can give take home. Even you take 2 days extra, nothing will happen. Methadone, yeah, you need to be careful beyond 100 milligram. But invariably you can handle the withdrawal symptom with methadone in 30 to 40 milligram. You not have to decrease. Second question, when to decrease and stop. Now this is a big gamble, and I don't think there is a standard guideline for that. It depends on the patient profile, patient seriousness, patient condition, and your confidence on him. Now, what I do clinically, or most of us do clinically, in this case I can tell what we do, is that after a certain period of time, when you feel confident, things are settling down, we ask patient, do you think is all right? Can you think decrease? Again you tell, you need not to decrease at all. Why should you decrease? We have a lot of patient will tell, okay sir, I will decrease a little bit and see. Some people will tell, no sir, don't decrease, I am not ready yet. So, but sometimes it's good to give, like this person, I have sometimes tell him, you decide, I am writing 3, can you decide what you want to do? So in their scope they do it. So, but the bottom line is that I think what has come in last few experience is that beyond certain level, decrease is not advisable. It's like you need 0.4, good enough, continue. And they're happy because you don't want to take the risk. And they also tell, I don't want to decrease because I don't want to go back that life which I used to have before, searching injection, finding. So I think this is how it is.
In fact, I will make a stronger pitch than you, because I have been in this game for a slightly longer period, and we've been using, we started using buprenorphine about 10, 12 years back. And with the same problem that, the issue at that time was people were saying that why are you giving one drug for another drug? What happens then, and this is something that we face with general public as well as mostly with other psychiatrists, that, it is seen as that the person is still addicted.
Yes.
You do not ask that question about when will you reduce and stop insulin. You do not ask that question, when will you stop and reduce, mood stabilizers in a person who has long-standing bipolar disorder. You don't ask that for schizophrenia. Why do you ask that here? So what people need to realize, and which is why I'm glad Prabhat brought up this later, is that the number of lives where people are staying, completing their education, keeping jobs, keeping relationships, looking after children, bringing up their families because of this. We need to get rid of this mentality that, this is, this is a vice. This whole vice versus virtue debate is no longer acceptable in 2015.
I think Dr. Sevin's question, Dr. Sevin, actually what I'm talking about, you have mentioned that what are the side effects of long-term buprenorphine and naltrexone? Naltrexone can cause hepatotoxicity. Now, just to clarify, this is buprenorphine and naloxone. Now, I think Dr. Atul will speak next time. Naloxone does not get absorbed in the body at all. The combination is given just to prevent the diversion. So, naloxone never goes to the body when you take a combination of buprenorphine and naloxone. Now, naltrexone, yes, it can cause hepatotoxic agent. Naltrexone is a sole agent, but it's very rare. So, using buprenorphine naloxone is, I don't think there is any risk of any side effect of hepatotoxicity. But studying that buprenorphine, you need to at least once a year check liver function for buprenorphine. Otherwise, safer stuff. I mean, you don't have to worry much about this drug.
For centers without buprenorphine, can we use tramadol for detoxification?
Okay, third case, the question by Devanjan is that can you use tramadol for detoxification, correct?
Not maintenance.
No, I mean, I have used spasm-proximum for detoxification, but after using buprenorphine, why not? What is the problem using buprenorphine?
No, sir, they're not available, sir.
Unless you get it, not available. It's like unless you look for that, not available. So we'll make available it. What is there?
It's not a medical issue.
Yeah.
If you look at the medical issue, if you look at what we did 20, 30 years back, We put people on dextropropoxyphene and later tramadol when it became available. We actually created a generation of people who started using drugs in a harmful way.
Yeah, I think my advice, our clinical team experience is that, Parthivan, do you want to speak something? Dr. Parthivan works he's following a cohort of buprenorphine maintenance treatment, opiate patients. Do you want to tell your experience?
Yes, sir. Actually, I am following up people who have been already started on buprenorphine for the last 1 year. And I am just following for the initial 6 weeks. And I have seen some dramatic changes in their life, particularly regarding their occupation. As you already pointed out, we have some cohort of people who came together who used to meet at, even though they were working at different places, they meet twice or thrice just to take the opiate to control their withdrawal symptoms. And they never go beyond Karnataka state to control its withdrawal symptoms. After starting these treatments, people started functioning extremely well, and the level of functioning, which is so dramatic, people used to come, even though from North India states, it's not a problem for them. And the other thing is the level of craving and the presence of psychiatric symptoms, psychiatric other comorbidities, which is not supposed to intervene in this opioid dependence treatment, particularly this buprenorphine maintenance treatment. And even though we think that the other comorbidities, psychiatric comorbidities, medical comorbidities may intervene, but and the level of craving is also not so significant to intervene in this dropout of people. And one thing which we have recently started looking on is people who has a very less motivation at this time starting of buprenorphine treatment are highly likely to drop out of this treatment. And the people who has injected drug abuse, there are high chance for this frequent dropout from the treatment. So the best way is to handle them is to know what are the risk factors before starting this buprenorphine treatment, and to do a simple motivation questionnaire like a change questionnaire, which is available easily. Contains some 20 questions before starting buprenorphine to assess the level of motivation. And one thing which is very surprising in our country when compared to other states who have done the similar studies, with the level of social support which played a very significant role in our studies, because recently I have seen about a few of my patients who is on regular treatment. The main reason for being on regular treatment is not only because of the benefit associated with buprenorphine, rather they frequently reported only because of their family support, who bring them very frequently as they are functioning well.
See, I think that's a very important point. Just medicine obviously doesn't cure. You need to have support, and
I think just to support Parthivan, this patient whom I just presented, he was almost some 15 years used to different form of opioids, and he himself tells that because it was inadequate dose, he continued taking above it, but when the dose was increased to optimum, he had intense craving for opioids. So for last 1.5 years, he tells that I can never ever imagine that 1.5 years I will stay totally without opioids. And even in the severe depressive phase also, he has never gone back to those drugs, while he had complete access to all of them.
Yeah, so that again shows how a good pharmacological agent used properly can do wonderful job in helping the patients. And at the end of the day, is the bottom line. Any final question? Okay. Ravikant's question is: duration of use of methadone and buprenorphine, 1 to 2 years enough if craving is reduced? Ravi, I'm not sure. Basically, the people see, as I told, there's no guideline for the same, but I think definitely at the end of 1 year, you can have some discussion with the person and then decide whether you want to cut down or how was craving or cut down. One question I forgot to answer, Saurabh's question about the urine testing. Now, Saurabh, the urine testing in the beginning of the, let's say 5 years back, they used to make a very strict criteria. Like anytime patient comes back for refilling up, represcribing buprenorphine or methadone, you have to do urine test, which is not so now. And people realize that is not going to make any change. But what normally we practice in our setting is that we do once in 6 months a urine check or SOS urine check, not to punitive to the patient, not to club his dick, to know that whether often what happens, person uses the extra opioid when he has not got the optimal buprenorphine. People feel shy to ask you. It's like Indian people know. with the hungry, they still not ask. Okay, fine, one chapati is okay. So if person urine is coming positive, the first question is to ask: have I given the proper opioid dose? Have I, is my prescription good enough? Or I have been thinking of 6 milligram, 8 milligram, 10 milligram like that. So that is the first question. So doing the urine test is to check has he used something extra, and if he has used something extra, increase the buprenorphine dose further and take it forward. So it is not a mandatory thing. Okay, I think any questions, any comments? All looks like okay. So I think if there are no questions, should we stop now? Nobody looks like moving. Okay. Thank you all of you. Thanks.